Hi everyone. Today I am going to talk on autonomic nervous system. Now just an introduction. The nervous system is divided into two major parts. One is central nervous system, which includes brain and the spinal cord, and the other is peripheral nervous system. The autonomic nervous system, which is also known as involuntary nervous system, is the system of the within the nervous system which regulates the involuntary functions of the body, like heart rate, blood pressure, respiration, etc. Then we have somatic nervous system, which is primarily responsible for controlling the movement of the skeletal muscles. Now, coming to the autonomic nervous system, it is classified into three components. One is called sympathetic nervous system, also known as thoracolumbar outflow. The other is known as parasympathetic nervous system or craniosacral outflow. The enteric nervous system, which is basically the component of sympathetic and parasympathetic, along with sensory component through the spinal cord. The enteric nervous system, which is mainly confined to the GI tract, has got two major nerve plexus. One is known as Auerbach plexus or myenteric plexus, which is between the muscles for contraction and relaxation. The other one is called Meissner's plexus, or also known as submucous plexus, which is for secretion and absorption in the GI tract. So the nomenclature of enteric nervous system is relatively a new terminology, because broadly speaking, autonomic nervous system is composed of sympathetic and parasympathetic, and enteric nervous system is a part of the sympathetic and parasympathetic nervous system. Now, as we have seen, the sympathetic is known as thoracolumbar outflow, and parasympathetic is also known as craniosacral outflow. Now, this nomenclature is based on their origin. Like sympathetic nervous system is originating from the thoracic and lumbar segment of the spinal cord, whereas parasympathetic nervous system is originating from the brain and the pelvic component or the sacral component of the spinal cord. Now, if you can see in this picture, the T and L, that is thoracolumbar, these nerve fibers, which are basically preganglionic, they are starting and ending into the ganglion. The ganglion is actually the collection of the nerve cells. They are present along the spinal cord. Now, the preganglionic fiber, they go to the ganglion, and from the ganglion, the postganglionic fiber, they originate and they distribute to the various organs of the body. Like if we see in the sympathetic component, the structures which are supplied by sympathetic system are eye, blood vessels, salivary gland, heart, lungs, adrenal medulla, liver, GI tract, bladder, genitalia, etc. If you see on the other side, it is parasympathetic nervous system, which is also known as craniosacral, starting from medulla, that is a part of the brain. So there are four cranial nerves which are part of parasympathetic nervous system. That is third, that is oculomotor, seventh, that is facial, ninth, which is glossopharyngeal, and 10th is vagus. So all these four cranial nerves, they are starting from medulla and they are supplying to the respective organ of the body. Like third cranial nerve is going to the eye, the seventh is going to the lacrimal gland, the ninth is going to the salivary gland, and 10th is going to the heart, lung, and upper GI tract. And if you see the last sacral component, the preganglionic fiber or preganglionic parasympathetic fiber from the sacral component or the sacral part of the spinal cord, they are originating, they are going to the pelvic ganglion, and from the pelvic ganglion, the postganglionic fiber is starting and ending into the lower GI tract, the bladder and genitalia. So this is the broad structure of the sympathetic and parasympathetic nervous system. Now, there are two neurotransmitters which we will discuss later, which are concerned with these autonomic nervous system. Coming to the parasympathetic one, the main neurotransmitter of parasympathetic nervous system is acetylcholine. So just to have a view that how it is synthesized, this picture which you can see is actually the terminal of a neuron, the ending of a neuron, a single neuron. Now the acetylcholine is synthesized in the neurons, within the neurons. The precursor is choline, and this choline is entering into the neurons through the membrane, and after entering into the neuronal cell, it combines with acetyl coenzyme A. So acetyl coenzyme A plus choline make acetylcholine. And this synthesis of acetylcholine is by an enzyme called cholinesterase transferase, choline acetyl transferase, CHAT, as you can see in this picture. And then this acetylcholine, which is synthesized in the neurons, is now ready to enter into the storage vesicle. Acetylcholine does not move freely into the nerve cell because it can metabolize. So that is why it enters into the protective shell or protective vesicle, and this acetylcholine, by the help of certain transporters, it enters into the vesicle, are stored along with the ATP and substance P. Once this vesicle is having acetylcholine along with certain co-transmitters, it is ready for release in case if there is a nerve stimulation. Now when there is a nerve stimulation, you can see on the right side, the calcium enters into the nerve cells, and this calcium causes the fusion of vesicle with the synaptic membrane. And this fusion will cause, at the end of the fusion, there is a process of exocytosis, and this the membrane dissolves, and the acetylcholine which was present in the vesicle, it releases and it comes into the synaptic cleft, as you can see in the bottommost part. Now the acetylcholine which is released in the synaptic cleft is now available for action at the postsynaptic membrane. Some of the acetylcholine is taken up by the membrane again to act on the autoreceptors, and most of them is metabolized by the enzyme acetylcholinesterase. So this is the fate of acetylcholine into the nerve, and you can see that at every step of acetylcholine synthesis are in this pathway, the chemicals or the drugs can modify the action of acetylcholine. For example, the synthesis of acetylcholine can be blocked by hemicholine because it does not allow the entry of choline into the nerve cells. Similarly, acetylcholine may not enter into the storage vesicle by vesamicol, which inhibits the storage of acetylcholine. Then, so these hemicholine or vesamicol, they are basically the anti-acetylcholine drugs or anti-cholinomimetic drugs. Once the acetylcholine is there into the vesicle, and once it is released, this can be inhibited by botulinum toxin, this release of acetylcholine, and so this function of acetylcholine is also inhibited. Similarly, the enzyme which is acetylcholinesterase at the synaptic cleft responsible for metabolism of acetylcholine can be inhibited by anticholinesterase drugs, which will prevent the metabolism of acetylcholine, causing more accumulation and having parasympathomimetic effect. So we will discuss all these components or all these drugs in the subsequent sessions. Like acetylcholine, in the parasympathetic system, there is noradrenaline as a neurotransmitter in the sympathetic system. So if we see the sympathetic nervous system as we have seen in the previous slide, in this also the noradrenaline is synthesized into the nerve cell, and the precursor or the precursor of noradrenaline synthesis is tyrosine. The tyrosine enters into the nerve cell and then it is converted to DOPA by the help of enzyme tyrosine hydroxylase, and then by the help of enzyme decarboxylase it is converted to dopamine. This dopamine is then available to enter into the storage vesicle. Now here is the difference. Here noradrenaline is not synthesized into the nerve cell. It is synthesized after dopamine enters into the vesicle. So dopamine enters into the storage vesicle where noradrenaline is synthesized and is stored along with ATP and other neurotransmitters. And again, once it is stored into the storage vesicle, and in case if there is a nerve stimulation, the calcium comes in, there is a fusion of vesicle with the membrane, there is a process of exocytosis, and then there is a release of noradrenaline along with other neurotransmitters. And here also the pathway can be disturbed or it can be intervened by various chemicals at various levels. For example, the enzyme tyrosine hydroxylase can be inhibited by tyrosine, which will prevent the formation of dopamine. Similarly, once the noradrenaline is released into the synaptic cleft, it can act on the postsynaptic receptor, which are alpha and beta. It can, again, most of the noradrenaline which is released into the synaptic cleft is reuptaken by the presynaptic membrane, goes inside the nerve again. And this process of reuptake can be inhibited by certain drugs like cocaine or tricyclic antidepressants. And so the uptake, once it is inhibited, there is more accumulation of noradrenaline into the postsynaptic or the synaptic cleft, leading to its action. So here we can see that the effect of noradrenaline or the action of noradrenaline can be interfered or it can be modified by intervention at different levels. We will discuss these points in the subsequent slides. Now this is just a picture to demonstrate that parasympathetic and sympathetic, which are the neurotransmitter at different levels. So we can see that parasympathetic, because once the fiber of the nerve starts from the origin of brain and the spinal cord, it goes to the, before entering into the organ, it goes to the ganglion. And from the ganglion, the postganglionic fiber starts and they go to the organs. Now if we consider parasympathetic system, which starts into the brain, the presynaptic fiber which goes to the ganglion, and at the site of the ganglion, the neurotransmitter is acetylcholine, and after the postganglionic nerve starts, and at the site of organ, that is organ and smooth muscles, again the neurotransmitter is acetylcholine. So we can say in the parasympathetic system, the preganglionic or the acetylcholine is present at the ganglion as well as it is also present at the end organ. If we see the sympathetic nervous system, primarily sweat glands, here we find that here also the acetylcholine is present into the ganglion, but at the level of sweat gland, it is acetylcholine again acting on the muscarinic receptors. But other than sweat gland, if we see the sympathetic nervous system, we find that at the ganglion there is a neurotransmitter acetylcholine, but in the organ the neurotransmitter is noradrenaline, which is acting either on alpha or beta receptors. If we go to the kidney and other vessels or blood vessels, here also we find that in the ganglion the neurotransmitter is acetylcholine, but in the end organ it is noradrenaline, or it could be dopamine, because dopamine is present also, or dopamine is present in the kidney or renal vasculature. Then if we see the adrenal gland or adrenal medulla, we see that here the neurotransmitter is acetylcholine. If we see the somatic nervous system or the skeletal muscle, we find that the neurotransmitter is acetylcholine, which is acting on the neuro or the nicotinic receptors. So here, broadly speaking, we can say that all the ganglionic or the preganglionic nerves, they release acetylcholine as the neurotransmitter, whether they are sympathetic or parasympathetic. But in the postganglionic system or the postganglionic nerves, the sympathetic nervous system has got noradrenaline and parasympathetic has got acetylcholine. The skeletal muscle at the neuromuscular junction, they have acetylcholine as a neurotransmitter. Now coming to the autonomic receptors. The cholineceptors, also the receptor for acetylcholine, they are broadly muscarinic and nicotinic. The muscarinic receptor is subdivided into M1, M2, M3, M4 and M5. The nicotinic receptor is subdivided into NN and NM. This NN stands for nicotinic at the ganglion, and the NM represents nicotinic receptor at the skeletal muscle or at the muscle. So there are two types of nicotinic receptor. Similarly, in the sympathetic system, these adrenoceptor is divided into three main components. One is alpha, the other is beta, and the third one is dopamine. Now alpha is subdivided again to alpha 1 and alpha 2. The beta is subdivided into beta 1, beta 2 and beta 3. And dopamine is subdivided into D1, D2, D3, D4 and D5. Now dopamine receptors are mainly involved in the brain functions, except that dopamine 5 is having some role into the renal vasculature and responsible for renin secretion. Otherwise, for all the practical purposes, dopamine is a central neurotransmitter. Now here, just broadly speaking, some of the important organs, if we see that they are supplied by sympathetic and parasympathetic both, and what is their function. So if you see the heart has got beta 1 more than beta 2, and the sympathetic stimulation leads to cardiac stimulation. So whenever there is a sympathetic stimulation, there is an increase in heart rate, there is an increase in force of contraction, there is an increase in conduction velocity of the heart. Whereas parasympathetic stimulation will cause inhibition of the heart. That means the decrease in the heart rate, decrease in blood pressure, decrease in force of contraction. If we come to the blood vessels have got alpha 1, alpha 2 and beta 2 receptors. And the blood vessels are primarily controlled by sympathetic system. Whenever there is a stimulation, there is a vasoconstriction, and so there is an increase in blood pressure. The parasympathetic effect on the blood vessels is negligible. Coming to the lungs has primarily beta 2 receptors, and by sympathetic stimulation there is a relaxation, and that relaxation causes bronchodilation, and this is the basis of using the beta 2 agonist in the treatment of bronchial asthma and COPD. Whereas parasympathetic stimulation into the lungs or in the bronchial muscles will lead to contraction or bronchoconstriction, leading to shortness of breath and other problems. And there are M2 and M3 receptors which are present into the bronchial tree or lungs. In the stomach intestine, we have primarily sympathetic nervous system, and also to some extent we have parasympathetic nervous system. Sympathetic nervous system are inhibitory, or they cause relaxation of GI muscles, whereas parasympathetic stimulation causes contraction or stimulation of the GI muscles. Same is with the urinary bladder. The urinary bladder is relaxed with sympathetic stimulation and it contracts with parasympathetic stimulation. Now coming to the drugs in the cholinergic system, broadly speaking, there are 5 or 6 categories of drug which can work on the cholinergic system or parasympathetic system. These are muscarinic agonists, which are also known as parasympathomimetics. They are muscarinic antagonists, which are also known as parasympatholytics. There is ganglion stimulating drugs. There is ganglion blockers. There is neuromuscular blockers. And lastly, there is anticholinesterase or cholinesterase inhibitor. So these are the 6 categories of drugs into the cholinergic system. We will take one by one. So today we are going to discuss only on parasympathomimetics. These parasympathomimetics are classified into cholinesters and natural alkaloids. The cholinesters, which are essentially 4 drugs: acetylcholine, methacholine, bithanicol, and carbachol. Now these drugs the cholinesters are poorly absorbed from the GI tract, and they are very short acting due to rapid elimination. So the clinical use of these drugs are almost negligible nowadays. If we see the properties of these cholinesters, we find that acetylcholine has got muscarinic effect as well as nicotinic effect, but it is extensively metabolized or hydrolyzed by the enzyme, so it has no clinical use, it has no therapeutic use. The methacholine, which has got mainly muscarinic effect and having almost very low nicotinic effect, it is also metabolized but not to a very extensive extent, but the use of methacholine is primarily for the diagnosis of bronchial asthma. The carbachol is also not a very popular drug in medicine nowadays because of its high nicotinic effect and lot of side effects. Bithanicol has got primarily muscarinic effect, as you can see, without any nicotinic action, and it does not metabolize by the enzyme so quickly, so it is effective drug. Earlier it was used for certain conditions like bladder and gut hypotonia, but nowadays, because there are better drugs available, so there is hardly any use of bithanicol. The other category of parasympathomimetics are natural alkaloids, that is muscarine, which is coming from inocybe, clitocybe or Amanita muscaria. The pilocarpine coming from Pilocarpus, aricoline, which is coming from betel nut, which is Areca catechu. So these are the natural alkaloids with parasympathomimetic effect or cholinomimetic effects. If we see the action of these drugs or the action of parasympathomimetics, we see that on the cardiovascular system there is a decrease in heart rate, decrease in cardiac contraction, decrease in conduction velocity, and broadly you can say there is a negative chronotropic effect, negative inotropic effect, and negative dromotropic effect. They cause vasodilatation, and so there is a fall in blood pressure, and also there is a decrease in cardiac output. So we can say, as we have seen earlier, that broadly speaking, the parasympathomimetic drugs, they have got inhibitory effect on the cardiovascular system. Coming to the respiratory, they cause bronchoconstriction because they stimulate the muscles, they cause bronchoconstriction. There is an increase in bronchial secretion, and that is why there is an interference with the breathing problem. And so these drugs are not rather they are contraindicated in patients with asthma and chronic obstructive pulmonary disease. In the genitourinary system, they stimulate the detrusor muscle but relaxes the trigone and sphincter of the bladder, and so they facilitates the voiding and urination. So you can say that by the effect of parasympathetic stimulation, there is more frequent urination. The human uterus is not sensitive to parasympathomimetic, so they do not affect the uterus or uterine contraction. On the GI tract, we had seen that they have a stimulatory effect. So these drugs will increase the muscular contraction and motility. They increase the peristalsis. They relaxes the sphincter. So one important thing to note is that they increase the contraction of the muscles, but they relaxes the sphincters. And so that facilitates the movement of the GI tract. There is an increased secretion of the gastric acid and more salivary secretion under the effect of parasympathomimetics. Coming to eye, these drugs, they cause constriction of the pupil, that is miosis. There is a contraction of ciliary muscle which causes difficulty in accommodation and difficulty in vision. There is a reduced intraocular pressure due to parasympathomimetics because they cause constriction of the pupil. So there is a better flow, or there is a more drainage of intraocular fluid, leading to decreased intraocular pressure, causing its therapeutic use in the treatment of acute glaucoma. On the CNS, that is central nervous system, these drugs do not have a major role, but they broadly causes cortical arousal. There is now a lot of studies and a lot of reports that parasympathomimetics, they have role in the cognitive functions, they have a role in the motor control, they have role in appetite regulation, they are responsible for nociception, and there are so many other processes in the CNS which are controlled by the parasympathetic system. The therapeutic uses of parasympathomimetics, as you can see from our discussion, is the pilocarpine is used for the miosis and glaucoma. Ophthalmologists, they use pilocarpine eye drops for constriction of the pupil and also for the treatment of glaucoma. This is available in form of eye drops, 0.5 and 4%. The pilocarpine tablets are also available for the treatment of xerostomia and Sjogren's syndrome. Now, as we have seen that these drugs can cause more secretion of salivary gland and more secretion from other glands, so that is why in the dryness of mouth these tablets are given, and also the rare disorder Sjogren's syndrome, and there is a dryness of eye, dryness of mouth and other problems. So this pilocarpine is used in the dose of 5 to 10 milligram 3 times a day. But pilocarpine has a lot of side effects. So a better derivative of acetylcholine, which is known as cevimelin, is now available for the treatment of xerostomia and Sjogren's syndrome. This is used in a dose of 30 milligram thrice daily. It has got a longer duration and lesser side effect than pilocarpine. The bethanechol it was used for the treatment of urinary retention, diabetic gastroparesis, post-operative retention, myogenic and neurogenic bladder. As we have seen that this drug causes stimulation of the urinary system and GI tract. That is why it is used, or it was used. Nowadays, it is not that much used. But if at all it is available in the market, and it can be used as 10 to 50 milligram 3 to 4 times daily on empty stomach to reduce the risk of vomiting. The precaution of using these drugs, our contraindication is, as we have seen, is bronchial asthma, because it can exaggerate, because it causes bronchoconstriction. The same is for COPD. It should not be used in urinary and GI obstruction. It should not be used in bradycardia, because it causes further decrease in the heart rate, hypertension and hyperthyroidism, because patients who are having hyperthyroidism, if they take this drug, there is a risk of atrial fibrillation. The side effects of these drugs are very well understood, are abdominal cramps, because they stimulate the GI tract. There is a diarrhea, there could be diaphoresis, more sweating, because there is stimulation of sweat glands. There could be nausea and vomiting, because hyperactivity of GI tract. There can be disturbed visual accommodation, because it causes contraction of the ciliary muscles. There could be hypotension, and there can also be reduced in coronary blood flow, which may lead to cardiac symptoms or sometimes even angina. But most of the time, the topical use, as we have seen with pilocarpine and others, is generally safe. So the parasympathomimic drugs are not, because currently they are not very often used for most of the conditions, as we have seen. So there is not much of the risk of these side effects. And the topical use of pilocarpine for glaucoma and for the causing miosis will not cause this problem, because that is used only in form of an eye drop. Thank you. हाँ तुम बनाओ, तब तक हम देखते